Okay, good afternoon, everybody. We'll be starting the presentation shortly. No, that's loud enough. We'll be starting the presentation shortly. This afternoon, we'll be talking about chronic hepatitis B. I think because of time, we should almost start on time, actually, just that there's nobody. Hope you're not logging in on your phone. Maybe I was, in practice, maybe about 4 or so. Okay, six. Okay, so this afternoon we'll be talking about chronic hepatitis B. I think we should start, Abby. Because the presentation can last long, I think we should. I think I want to start now. So, good afternoon, everybody. This afternoon, we'll be talking about evaluation and management of patients with chronic hepatitis B. The topic is intentionally chosen. I believe that we will all agree that hepatitis B is a very common condition that we all see frequently. So I will encourage us to all fully participate in the presentation. And let's see the practice changing points we can pick out of the presentation. Okay, I'll be taking the topic. I wanted someone to give me some moral support before, but unfortunately, my colleague, gastroenterologist, is not available to join. Okay, but we've discussed the topic fairly thoroughly together. Okay, so we will try to follow this outline. We'll try to follow this outline. So by means of introduction, we all know that hepatitis B is a worldwide public health burden. And we know that it is estimated about 1/3 of the world population has been infected with chronic hepatitis B. That's 1 out of 3 people. And if we say about 1/3 of the world, we can all imagine that even a larger proportion of people in sub-Saharan Africa and Asia, especially Southeast Asia, where some of us consider to be the global capital of hepatitis B, the proportion there will be more, okay? And out of all these people that have chronic hepatitis B, 0.5%, that's 1 out of 200 people, will actually seroconvert annually. By this seroconversion, we mean that that would lose their surface antigen, that will become surface antigen negative. Peculiar to Nigeria, it's important to know that in areas of high prevalence like Nigeria, the transmission is mostly perinatal. That is, most infections are acquired around the time of delivery and also in early childhood from mother to the infant. And that's part of the major reasons why our hepatitis B problem is unique in this part of the world. Also, we also know that vaccination has reduced the global incidence. Of course, unfortunately, Nigeria did not start vaccination early. In most parts of the world, vaccination for chronic hepatitis B has started around 1995 or so, whereas Nigeria didn't start up to about more than a decade later, actually. Okay, so the people that were born maybe 2005 after, they can almost be sure that they were probably immunized. Those of us that were born before then were not immunized, at least in childhood. Of course, many of us had the immunization as adults. So it's hyper-endemic in Nigeria, and the overall prevalence is thought to be about 14%. That's a lot. It's thought to range between 10 and 40%. Particularly in Nigeria, again, genotype E is the most prevalent in sub-Saharan Africa, even though the genotypes are said to extend between, I think, K and H. And that E is actually associated with a poor response to interferon-based therapy. And that's why most patients that are tried on interferon in this part of the world, the response is usually poor. Additionally, it's quite associated with pre-core and core promoter mutations. And that's why most patients we see will be E antigen negative, not because they cleared the infection, but because they didn't have the E antigen ab initio. I think I've talked about this, so I'll skip it. This is just a structure of the virus. There's nothing too much to say about this. I'm not going to focus on this, but of course it helps us, at least to some extent, to understand many of the protein on which the serological assays are based. Okay, the genome, and that's the double-stranded DNA, is in the center. Okay, and of course that is encased just as a round by a E antigen that was called envelope antigen in the past, but it's just basically called E antigen now. And before we now have the core of the virus, which is that part in blue. But I think we won't spend so much time on this virology. So if someone encounters hepatitis B infection, what are the possible outcomes? We could have an acute infection, which is typically cleared in adults, but sadly in childhood, typically remains. The figures we quote is that in adulthood, in an adult that encounters the hepatitis B infection, about close to 90% will clear it, okay? I'll talk about that a bit more later, but the more symptoms they have and the more severe symptoms they have, the more likely they clear it. Whereas in childhood, when the infection is most likely to be silent, they tend to have chronic infection. We should also be aware that there can be occult infection in which the HBsAg gene may not be detectable, okay? But the HBV DNA will be detectable. So those are possibilities from acute infection. This lower part will come to it sometimes later along the line. Okay, so this line just reflects a bit of what I said just now, that from any acute acquisition of hepatitis B infection, in the ones that are acquired in childhood, most of them will proceed to chronicity, up to 95% in this slide actually. Whereas in adulthood, only a few percentage will go to chronicity, okay? The louder the infection is, the more likely it proceeds to chronicity. And of course, out of the people that get chronic infection, not all of them will get inflammation. Some of them will be just carriers. That is, if you look at for evidence of liver inflammation, it will be absent, both by using your ALT and by using liver histology or the things you can use to evaluate that, okay? But some of those, which according to these figures, even though it doesn't represent every part of the world, definitely, okay? But here, around 20% will go to cirrhosis, and then out of those, some will develop liver failure, and some will develop hepatocellular carcinoma. Okay, so I talked about this earlier, that the outcome of the infection depends on age at the time of infection, okay? Younger people, their immune system is very naive, does not even recognize that an infection takes place, unlike adults in which they mount a vigorous immune response to the virus and are more likely to clear the virus, okay? Also, people that have more symptoms, people that have more symptoms are more likely to clear it. And of course, older people, I hope you can see my mouse, older people are more likely to have symptoms, okay, and they're more likely to clear it. Whereas people that are younger, people that are at that extreme, they're less likely to have symptoms and they're more likely to proceed to chronicity. Okay, so again, the outcomes of an acute infection is mostly dependent on age. And you can see by the wide difference on this graph, from if someone was young compared to if the person was an adult by the time of at the time of infection. Okay, I mentioned this second part of this earlier in the slide that there's actually spontaneous clearance even in chronic infection. Spontaneous clearance, talking about this figure quoted about 1% of chronic carriers of hepatitis B will seroconvert in a year. Seroconversion means they've cleared the virus. Technically a cure. That is, they will be HbSAg negative and they will not be at risk of any of the long-term chronic complications of hepatitis B. Of course, it's technically a cure in that sense, but we should always remember that if you do a serological assay, there will always be an evidence that the person has been previously exposed to chronic hepatitis B. Okay, so this is a serological profile, which I believe that most of us know. I need to pace myself now. Of course, we know that HbSAg is the first evidence to appear in the blood is HbSAg, okay? And HbSAg is the antigen which the virus sheds, okay? HbEAg comes early. This serological profile that is on this slide is actually for an acute infection that is cleared. That is what this slide assumes, okay? HbSAg comes early, but once the person is clearing the stuff, you start to see anti-HBE, and of course, HbSAg disappears, and then anti-HBs comes out later. This anti-HBs, the presence of anti-HBs on the serological assay tells you that the person is immune, okay? So this only comes either through vaccination, one, or the person has cleared the HbSAg and the chronic hepatitis B. Of course, there's a gap between the appearance of HbSAg and the anti-HBs. In people that goes to chronicity, basically what you just have is that this does not go down. The red line just keeps on and on in someone that proceeds to chronicity. At the time, the way we define chronic hepatitis B is persistence of the surface antigen beyond 6 months, okay, which is 24 weeks. So that's chronicity. So by the time this proceeds, whatever the level is, by the time it proceeds on beyond that period, it's a chronic infection. This graph looks like this. Of course, I know that in our hospital, we usually just do the basic. We do the basic. We do the basic. Excuse me, just a second now. Okay. So yeah. Okay, so yeah, we do the basic HbSAg, which is qualitative. Qualitative that it just tells you whether it's there or not. Okay, but we know that there's a quantitative HbSAg. There's a quantitative HbSAg in which you can actually see the titer, and you can see whether the titer of the hepatitis B surface antigen is going up or going down. And we are likely going to adopt that probably soon. So, so this is a natural history of chronic hepatitis B infection. Okay, of course, I'm sure that we all know the old terminology, even though I don't want to dwell on this part. We all know the old terminologies of immune tolerant phase, which is the earliest stage in which the immune system is naive. That's what we see in most children, most very young people with hepatitis B. The immune system is naive, it doesn't recognize it. It doesn't mount any kind of response to the virus whatsoever. And in that setting, the surface antigen is there and high. Viral load is very, very high, but the ALT is normal, okay? Of course, the E antigen is present. So that phase has later, of course, been changed now to just phase one of the chronic hepatitis B. Later on, the immune system can recognize that virus and can mount up an immune response against the virus. At that stage, sometimes someone can get symptomatic briefly, but the most important thing you see at that stage, different from the first stage, is the ALT that goes up. Okay, and when that ALT goes up at that time, in the presence of a positive EAG, it tells you that the person is in the so-called immune reactive phase, which we now call phase 2. Okay? And then along the line, the person can proceed to this stage. That's this chronic phase. Now, those that not everybody passes through each of the phases, and some people might spend a very brief period in the phase that you may not even notice. Okay? So you can now go to this inactive carrier state, and that's the state in which the body has been able to, this immune response that was mounted in this phase. Don't forget that in this phase, the body cannot recognize that there's even anything going on. It doesn't know what's up. Okay? And here, the body is mounting a very strong immune response against the virus, and it's at this stage in which the person can lose the E antigen 1, the person can also be able to suppress the DNA, and after the war is over, the ALT goes down, the person becomes an inactive carrier. This phases is common, especially in the Western world. It's not so common here. And the reason why it's not so common here is that here we have a lot of pre-commutants, and that are ab initio E antigen negative. That is even right from outset, they didn't even have the E antigen. And that means you can't really talk about this phase. And most of the time you just find them either here or here. Okay? So a lot of patients can have this phase in which the E antigen is negative. And in the past, the main purpose of the E antigen is to actually assess infectivity, one, of course, and of course also viral activity. Because as I said here, when the E antigen becomes negative from positive, it actually suggests that the person has been able to mount a successful immune response against the virus, and the battle is being won, basically. Okay, but in Africans, especially sub-Saharan Africans, in which the pre-call mutation is very common, and this is negative, oftentimes you have this negative, whereas the viral load is high compared to this, and the inflammatory markers is also high, and we call it E antigen negative chronic hepatitis. And of course, most of these should be treated. We can also have a resolved infection. So, of course, a talking point for chronic hepatitis B is screening. And the first question we need to ask ourselves is that who should be screened? There can be routine population screening, which is, we can argue for very endemic. I've told you that Nigeria is hyper-endemic for chronic hepatitis B. So there can be routine population screening that you're just screening everybody, but it's not practical many times. And even in Nigeria, where it's quite endemic, it is not done, okay? And of course, there's the opportunistic screening. That is, people are screened in certain settings, okay? There's also the high risk and selective screening, and of course, before vaccination in adults. I'm sure, unfortunately, in many places, people get vaccinated without checking their status first, which leads to a confusion, a sense of false protection, and even slightly higher chances of immune complex issues. Okay, so I've mentioned the general population screening, and it's usually often spearheaded by NGOs. They do it in churches sometimes. They just try to screen a whole population somewhere, okay? And of course, there are specific programs, just like HIV programs. There are programs for hepatitis B in which people are screened, and people that test positive usually are just referred to an hospital. Of course, many people too do outreaches. I'm not sure how many people have done outreaches there that they just decide to go to social community and screen them for hepatitis B. Opportunistic screening is often in pregnancy, okay? Also in blood donors and organ donors. Screen them, and then usually they just pick them. Of course, many other people should be screened. Of course, there are many other settings which is not really reflected. It's almost like opportunistic as well, like doctors, for example. So high-risk groups, people that are more likely to have a severe consequence of the chronic hepatitis B, should also be screened. And that includes people who are immunosuppressed, either people that have HIV, also mono immunosuppressive conditions, leukemia, and people that you want to immunosuppress with treatment. So I want to give it someone with myasthenia gravis or SLE high-dose steroids. I want to give someone chemotherapy. They should be screened because immunosuppression increases the chance of reactivation of that virus, even if it was dormant before. And the person can present with a flare-up of hepatitis B that has been lying dormant for a while. That same applies to organ recipients. Of course, contact of infected persons should be screened. And of course, people with chronic diseases, especially dialysis patients, should have hepatitis B screening. So when we're seeing patients with chronic hepatitis B, if a patient is referred to you with chronic hepatitis B, or you did a test for a patient and the patient tested positive for hepatitis B, how should we assess such a patient? Usually, most of the cases we see here are chronic cases, okay? And it's not so difficult to know, even though, of course, we might say it can take you up to 6 months to know one. You might use the panel, 5-in-1 panel, to judge whether it's acute or chronic. If you see the E antibody, ideally, it takes a long time for that to form, and it should be chronic. But don't forget that I said that in the environment, many patients are even so many people are even E antigen negative ab initio, so that may not count so much. Okay, but if someone does not have any recent symptom and was just found routinely, can as well assume that it's chronic. Okay. Okay, so when we're evaluating patients, we should look for risk factor for acquisition, family history, whether there's anybody in the family. Because I mentioned that perinatal transmission is common in this part of the world, one, and that transmission among that most infections are acquired in childhood. It's common for people to have their siblings and the mother affected for each person. So for each person you find, you think of the mother, one, because of vertical perinatal transmission that's around delivery, and also the siblings. If they got it from the mother, the other could have gotten it from the mother, one. And then during childhood, while playing in childhood, rubbing bruises against bruises often transmits it. And again, that's the most common mechanism of transmission in this part of the world. So it's often advisable to tell you to ask them to get their sibling screened. It's far more likely to be present in a sibling than in a spouse, because sexual transmission occurs, yes, but it's far relatively quick compared to, hope not in chief. Okay. Compared to blood-related transmission. So occupation, you should ask, and it's very important to ask. I've seen many laboratory workers, not necessarily in this hospital, that came with hepatitis B, and so if you don't ask the occupational risk factor, you may not pick it. Doctors, nurses that have chronic hepatitis B. And not just the person, also family members. The husband can get it and then transmit it to the wife at home, etc. Previous blood transfusion, it's easy to miss this if you don't ask, and it happens. In fact, it's very common. It is thought that most of the hepatitis C now in the Western world is from blood transfusion before I think 1981 or something, before they started screening for chronic hepatitis C in blood. So unsafe needle practices, sharing of sharps, particularly clippers, but more importantly, circumcision, scarification marks, local ovulectomy, quack dental procedures, people that ask other people to cut nail for them, and they don't try to see whether the blade was sterilized or, was brand new or not, okay? And of course, high-risk sexual behavior. These are all risk factors that we should evaluate and document in our history. And symptoms, we should ask for history suggestive of acute infection. If the person is asymptomatic and it was just found during a routine test, it is a chronic infection until otherwise proven. And then ask for history of previous jaundice. Previous jaundice can suggest the time at which the person acquired the infection, that is one. It could also suggest previous flares. Don't forget that many times chronic hepatitis B can happen and there can be flares along the line, especially at that immune reactive phase that I mentioned earlier. You should also look for features of complications, things that can suggest portal hypertension, things like ascites, pedal edema. Look for evidence of liver failure or things that can suggest malignancy. It's important not to overlook any of these things. And many people could have had a test either positive for years or something prompted them to do it. Okay, so it's important to ask for these things, including things that can suggest malignancy, and weight loss or pain in the liver area are the things that most commonly would suggest malignant transformation in someone that has chronic hepatitis B. We should also look for risk factors for complications. People who on certain medications can increase their risk for complications, either potentially hepatotoxic medications, one, or medications that suppress the immune system and will weaken the person's ability to contain the virus. Alcohol history is important, family history of cancer, diabetes, other infections including HIV and hepatitis C, and history that can suggest immunosuppression. We should also look for stigmata, peripheral stigmata of chronic liver disease. I want to believe that we all know this fact and we should look for them. Making a diagnosis of a complicated chronic hepatitis B is a clinical thing, ab initio. The tests may not give you the clues enough. It's a clinical thing primarily. In fact, for some people, it's some clinical things you see before you ask the person to go and check for hepatitis B, and so there was a guy that Dr. Iseko was gynecomastia. Gynecomastia the person had, and by the time they did the viral load, it was over almost 1 billion, one crazy number. Okay, so we should look for these things whenever we're assessing anybody with chronic hepatitis B. I won't go into the details of this because of time. Okay, so we should examine the patient thoroughly, we should look for peripheral stigmata, make sure you measure the liver span, even though it's not a very reliable clinical sign, but we should measure as much as possible, and you should look for evidence of ascites, because by the time you see that, the game changes, and the aggression with which you pursue completing the patient's evaluation is more. Okay, so we should do routine labs for people with chronic hepatitis B. We know these things already. We should do a test we call a 5-in-1 panel here, but basically we should do a hepatitis B panel, which includes the surface antigen, the surface antibody, the E antigen, the E antibody, and the core antibody. I didn't put a slide that puts together how to interpret this, but I believe that we should be able to interpret whatever combinations of this we'll see. Okay, HBsAg in someone that's been infected usually is there and is there lifelong usually. But I mentioned earlier that just less than 1% per year of people with seroconvert and lose the surface antigen. In those people that have encountered it before, the core antibody will remain positive, even though they've cleared the surface antigen. So that's one. I've told you that most people in Nigeria would be E antigen negative. I think 80% from some series, okay? The surface antibody in chronic hepatitis B is usually negative, except if the person has overcome the infection. I hope you remember the graph I showed earlier. Except if the person has overcome the infection and the antibody is now there. Of course, vaccination also can trigger production of the antibody, and usually by the time you can detect it from the panel, it suggests that the person is immune to it. And usually by the time you are seeing HBsAb, you should not see HBsAg. Okay, we should do the complete blood count, and what we are looking for primarily is a platelet. Okay, low platelets is a feature we find often in cirrhosis, and of course that's because of the effect of the hypersplenism on platelet count. It reduces the platelet count. We should also remember that one of the ways of assessing fibrosis or estimating fibrosis in chronic hepatitis B is by doing what we call the APRI score, which is by looking at a ratio of the percentage increase or percentage normality of the AST to the platelet count. Okay. We should also do other viral screening. Sometimes you'll meet this, and it's important to do it in everybody with chronic hepatitis B at least once, even if it is just from outside. There should be a documented HIV status and HCV status because it totally affects how you treat the person. Liver ultrasound scan is also important, of course, for many reasons. Basically, one, to look for features of chronic hepatitis, 1, 2, to look for features of cirrhosis, and 3, as surveillance for hepatocellular carcinoma. Of course, the viral load is important. And there's some other tests that are important but are not routine, and that includes the alpha-fetoprotein, which is one of the tumor markers for hepatocellular carcinoma in patients with chronic hepatitis B. Sometimes we need to do the genotype. Okay, I mentioned earlier that the genotype, we have genotype A to H, basically. There's some other fancy ones, or basically A to H. E is the most common in this environment, and I mentioned earlier also that E is poorly responsive to interferon-based therapy, okay? So especially when there's resistance in treatment or if you are considering interferon, unfortunately the genotype is slightly hard to do here, but it's still available. And of course, I believe that we know that we routinely do genotype for hepatitis C, okay? So liver biopsy is also important. It has a role, even though the role has been diminishing in recent years. And other tests that can also be done includes assessment for fibrosis, including the transient elastography and also the other serum-based fibrosis markers, which I might talk about a bit of them. Quantitative HBsAg is being more widely used now, even though we are yet to fully adopt that, but I think it's something we are likely going to do in the near future because it has a role too in giving guidance for treatment. And rarely, there may be a need for mutation assays, and of course, that's usually just in people that have been shown to be non-responsive or resistant to treatment. Okay, so basically these are the tests that we do, and usually we do this at diagnosis at an initial encounter, and some of them we do frequently over time, either both in treated and in untreated patients. These tests on this first page should be available for every patient being evaluated for chronic hepatitis B. Okay, and of course the one on this next page, some need, some may not need. Okay, of course, it's important. We know that one of the major complications, one of the things we want to look out for in patients with chronic hepatitis B is evidence of fibrosis. Okay, there are slides on it along the line, but ultrasound is, we use ultrasound to pick, part of the reason why we do ultrasound, number one, is to look for features of chronic and active hepatitis. Secondly, is to look for features of cirrhosis. And thirdly, of course, I said, is the surveillance for hepatocellular carcinoma. Now, the level, the time at which ultrasound picks cirrhosis is usually far along the line, okay? And in some people, we need to make a decision on treatment and want to know how much viral activity is going on, which you can find out with the DNA, how much liver inflammation is going on, which you can find out with the ALT and co. Okay, but I want to know how much fibrosis is also going on. And the way you can assess that fibrosis, by the time you're picking it with ultrasound, is far gone, okay? These tests can pick it earlier, like the imaging test that we call transient elastography or fibroscan, and then some other humoral markers like the Harpy score, which I nicely showed in this side of the screen. The way we calculate it is just take the patient's ALT over upper limit of normal. They use 40 here, but it's usually more prudent to use 30, okay? And then platelet count raised to power 9, just that figure, then times 100, and we interpret it like this, okay? If it's less than 0.5, it's great. It's likely no fibrosis, but if it's greater than 2, it's very likely that the person has some cirrhosis. And you can do it, you can eyeball it by just looking at platelet count. By the time your platelet count is getting less than 150 or getting less than 100, you should raise your eyebrow and make sure you calculate, especially if the AST is elevated. The AST is elevated and the platelet is a bit low, almost invariably, Harpy score is going to be high. There are some other tests like the FIB4 test and the Fibro test, which uses a combination of various markers that some of them are tricky to do, microglobulin and some other things, just to calculate and assess how much fibrosis is likely going on in the person's liver. But at least this one is easy for us to do. And in the basic panel of tests we do, the Harpy score is almost always easily calculatable. If you don't calculate it, I'll just remind you that if you see the ALT slightly high and platelet slightly low, even if every other thing looks normal, raise your eyebrow, okay? Don't forget that it's possible for HBV DNA even to be low or low normal, ALT to be low or low normal, and there are still some significant fibrosis happening in the liver. Okay, so which patients are most likely to progress to cirrhosis and hepatocellular carcinoma? Number one is the severity of the chronic injury or fibrosis, which we would have assessed with the DNA, ALT, and markers of fibrosis as well, okay? So, of course, duration of infection also matters. The longer the duration of infection, the more likely. And that's why the burden of hepatitis B related cirrhosis, liver failure, and hepatocellular carcinoma is very high in this part of the world. Why? Because most of our infections are acquired in childhood. And because they are mostly acquired in childhood, by the time we are seeing them in their 30s and 40s, the duration of infection is long, okay? That immune reactive phase, and by the time you look at the phase from which hepatic inflammation starts, many often at times is in their 20s and 30s. So by the time you are seeing the patient in the 30s and 40s, inflammation in the liver has taken place for a very long time, and the chance of cirrhosis and HCC is much more higher. Concomitant liver diseases induced by alcohol, diabetes, cholesterol, that's alcoholic, both alcoholic and non-alcoholic fatty liver disease, increases the chance of progression, okay? And progression to hepatocellular carcinoma occurs at this rate. This is from one source, okay, but I think I have some other sources I quoted later along the line. The role for liver biopsy has reduced more recently. I believe we all know that already. And that's because we have more research data on the correlation between viral load, ALT level, even HBsAg antigen levels, okay? and the non-invasive fibrosis assessment tools, the yield from that over years has quite relegated the role of liver biopsy. Okay, but it's still there. Many cases, especially when you are not sure that treatment is indicated. I gave some situations now, and unfortunately, many times this kind of patients, when there's no reliable liver biopsy facility available, most of them just get treated basically. So patient is hepatitis E antigen negative, ALT is normal, but the DNA is high. Or the DNA is low, but the ALT is high, and you're not sure what's making that ALT to be high. But this particular last one is the very interesting one many times, is patients that has a low DNA, low HBV DNA, low ALT, but you can find evidence of liver disease in someone, because it's easy to treat, and many times we do that, okay? But that liver disease, that evidence of liver disease you are seeing can be from something else, totally, maybe something totally different. That the chronic hepatitis B is just a innocent bystander. Because the fact that chronic hepatitis B is very common. We said that it's a prevalence of roughly 14% in Nigeria. And that means there will be many people that alcohol that is causing their problem, is hemochromatosis that is causing their problem, is something else. Even the medication they're using that is causing the problem, but you just attribute it to the hepatitis B, and you're flogging the hepatitis B that the viral load is very low, and it's not going to solve the problem. So that is the narrow aspects in which liver biopsy is still relevant in the management of chronic hepatitis B. So management, the first thing that is important is that the management should be initiated and monitored in specialist settings. It's not a GP business, really, okay? Some maintenance parts can happen, maybe someone on treatment, for example, or someone not on treatment, the in-between parts, but definitely has to be monitored, preferably initiated and also monitored at least at intervals, maybe minimum of yearly in specialist setting. The patient has to be educated about the diagnosis, the long-term nature, the long-term nature of monitoring particularly. It's easy for someone to cough up money for viral load at home visits, but it's long term. Sometimes if someone wants to check it in 3 months and I tell them that, cool down, you're going to do this thing till you're 70. It's based on existing science. And so let the patient understand that this is a long-term issue. That's one. Secondly, of course, we want to reduce risk, especially a risk to other people. They should not infect their family members, their children, and things like that. So we take measures to do that. And that involves screening family members and select contacts, even possibly sexual contacts. And of course, taking measures to immunize family members that are negative. Many times you forget the family members, and it's not good. Okay, so we should screen family members, immunize ones that are negative, and the ones that test positive should be on some sort of follow-up. Alcohol cessation is important, should be 0. Okay, so there's no room for any level of alcohol intake in chronic hepatitis B patients. And of course, we should explain the role of pharmacological therapy to them, because many of them are just eager that they're having sleepless nights over this chronic hepatitis B. Doctor, start me on treatment. But there's a Yoruba adage that suggests that a war that you're going to fight for 100 years, you don't have to be in a rush to start. Okay, so you should be able to counsel them that they should relax, let's evaluate. Most people just need monitoring, and irrespective of treatment, there will be a need for monitoring. And the HbSAg is likely going to be there for life, apart from the 1% annually that I mentioned that seroconverts. So who should be treated? People that have evidence of viral activity, basically by high viral load. And high viral load, of course, I know is a subjective term. High is usually greater than 2,000, greater than 20,000 units per, I think it's liter or something. So greater than 2,000 units is high, greater than 20,000 is definitely high. We need to be able to interpret it, particularly the way it comes out in our own lab results. Usually we write times 10 raised to power something, okay? So if I write 2 times 10 raised to power 1, that is 20. Okay, if I write 2 times 10 raised to power 2, that's 200. And you have to look at it carefully, because if you make a mistake of a decimal point in the interpretation, it can backfire, okay? So that's one. Evidence of persistent active inflammation, and that is defined by your ALT levels primarily. Okay. Secondarily, maybe appearance on ultrasound scan perhaps, but primarily by a health level. Because evidence of cirrhosis or its complications, now there's no grammar there. The person has to be on treatment. And the evidence may be direct or indirect, okay? So, so these are the categories of people that should be treated. The categories of people that should not be treated. Let me quickly go back to this slide, sorry. The categories of people that should not be treated, of course, these people in the immune tolerant phase, especially in children, so pediatrics particularly. You see the HbSAg is high, E antigen is present, and that's important, present. The DNA level can be very high, but the ALT will be normal. At that phase, there's really no point treating the person, and the person should just be observed, okay? People in this phase 2, usually they are just observed, okay? And then from here, particularly this intermediate phase, definitely should be treated. Yeah, this phase, if the E antigen is negative and you still have HbA/BV DNA in this range, of course, the person should be treated. So usually, that is the key guide to patients that require treatment. And our treatment goals are, number one, we want to prevent cirrhosis, we want to prevent liver failure, we want to reduce the risk of hepatocellular carcinoma. And we know that if we reduce the viral load, one, if we reduce hepatic inflammation, we are going to achieve this thing I put up here. So if you reduce the viral load and you reduce hepatic inflammation as defined by the ALT, the risk of progression to cirrhosis, liver failure, or cancer is much less. In addition to that, we are going to be reducing the risk of transmission to other people, to household members, even to people of the world, because just like HIV, the higher the viral load of hepatitis B is, the higher the risk of transmission. Of course, if you have extrahepatic manifestations, especially glomerulonephritis and nephrotic syndrome, it's important, that's the benefit of treating. And of course, HbSAg seroconversion can happen with treatment. Okay, so there's pegylated interferon that has been in use for a very long time. That's the injectable treatment. Unfortunately, of course, it's expensive. I mentioned earlier that most of the genotypes found in this type of the world are poorly responsive to the pegylated interferon. It has antiviral and immunomodulatory properties, and that is why it is more likely to trigger seroconversion, both of the E antigen seroconversion and even the HbSAg seroconversion within a short time compared to the other available treatment. Of course, we know that the dosing is weekly subcutaneous injections for almost a year. In patients who are E antigen positive patients, they get seroconversion they get E antigen seroconversion in up to 40%, and it's durable in most of them. Only about 6% of them would lose their surface antigen. Don't forget that I mentioned that the background rate of loss of the surface antigen is about 1%. So this drug, if you're on this treatment, increases to about 6%. That is in patients that are E antigen positive, which is not the patient we often have here. In E antigen negative patients, which is the kind of patient we often have here, it gives viral suppression in up to 60%, but it's only durable in 19%. And that's what I tell patients when I tell them about IFN therapy, that it only works in 2 out of 5 patients. Sorry, 2 out of 10 patients. That's 1 out of 5 patients. It's very little, okay? Of course, because of this, there is a need for markers for things that would, for you to be able to select the patients when it would likely work, and then that's where you should probably concentrate your firepower, okay? The HbSAg loss too in people in our environment is still poor. That's 4%. Okay, it's something, but it's relatively not high. So the candidates are patients who are HbA positive in phase 2 and carefully selected phase 4 E antigen negative patients. And the predictors of response amongst our kind of patients who are E antigen negative are patients that are younger. The younger people are likely to respond a bit more. That's one. But part of the other reasons why is that we should strongly consider using IFN in patients that are younger is because of the fact that if you're the risk benefits, favors benefit now, because I mean you're talking of many more years of oral agent. So it's, and in Many countries, for people that are less than 40, actually, even whatever their profile looks like, they still give them high FM first in wealthier countries, okay? But here, if you give someone a treatment for 1.5 M or 2 M, I'm not sure how much the cost is now, and then for 8 out of 10 of them, it didn't work, and they're having to be coming every Saturday to come and collect injection. They can fight with you. That's led to fight before. Okay? People who have high ALT and low viral load, just that combination, if you see that combination, the ALT is high, the viral load is low, and you're sure you think that the ALT elevation is from the hepatitis B, is a candidate for pegylated interferon. Genotype A and B are more responsive. Unfortunately, it's E we have mostly in our environment. Of course, it's less. There's less response in males, and once you see cirrhosis, the response is poor, and even IFN is contraindicated in the presence of cirrhosis. So, because of the cost of pegylated interferon, it is important to have some on-treatment predictors of response, or some things you see at, I've mentioned that is a 48-week course, or some things you see at quarter time and half time, that if some things are not there, it's better you consult the person's money and know that it's not going to work, will work. Okay? So, and that is the quantitative HbA1c can tell us. And I think a 3-log, I can't remember now, I think a 3-log or a 5-log reduction in the viral load count. Okay? That means going from 10 raised to power 7 to 10 raised to power, if you say 3-log now, 10 raised to power 4, just that number of zeros gone. If you see it along the treatment, it's likely that the person is going to respond. If you don't see it, you might as well save the person's remaining money. And so in the more recent guidelines, it's a quantitative HbA1c that was used to, so if it's still high, is at 24th week, that's at half time, the duration of treatment is 48 weeks, it's unlikely that they're going to be a successful treatment, and you should consider abandoning the treatment. Interferon is contraindicated in decompensated cirrhosis. Of course, it's also contraindicated in pregnancy. And the commonest adverse effects are things like flushing, low pancytopenia, all sorts of cytopenias can happen. And it's actually not so well tolerated unlike the oral agent. So people on interferon therapy should have their viral load liver function test every 3 months. They should also have their full blood counts and the thyroid function test because of side effects. I think it can cause hypothyroidism. And sustained viral load here is defined as viral load that is less than 20,000 units, preferably undetectable, okay? And that should persist after treatment by at least up to 6 months after cessation of treatment with a normal ALT levels. So we have many oral agents. This is a list of the ones that have been used. Tenofovir and entecavir are the ones that are mainly used anywhere in the world now. The other ones are only used during certain circumstances. Okay, so tenofovir is common. We have it here. It's not expensive. The viral suppression capability is very good, very high. Okay, normalization of ALT2 is very good, more than 80%. Okay, in people that were HbE antigen positive, up to 60% of them lose it. And after 7 years, actually, surface antigen loss also can happen in up to 12% of patients. So while we say that hepatitis B is incurable, and most people will remain positive lifelong, some people actually lose the surface antigen, that's true. Some people just as a minority, and it's not a direct treatment endpoint, and it's not used down to define a success or failure of treatment. There's also improvements in liver histology, and the most common side effect is nephrotoxicity and high phosphate. Particularly for tenofovir, resistance is very uncommon, and that's what makes it, for now, the most prized anti-hepatitis B drug. In fact, they said, some people say it has not been really documented, okay? Entecavir is also often used. It's also a first-line medication for it. Because it's less often used, it's a bit more costly, and there's a bit of resistance to it in some certain situations, but it's still a very excellent medication. In everybody on treatment for chronic hepatitis B, the DNA and LFT should be measured monthly, sorry, every 3 months until we cannot pick a viral load, subsequently 6 monthly. We should also do follow-up EUCR in patients on tenofovir. Sometimes treatments are combined, even though I've heard of sequential treatment as well before. So really, Pegylated interferon can be combined with the tenofovir or the entecavir, and then sometimes the tenofovir or entecavir is combined with another of the oral agent, but the role of it is very, very minimal. So can we stop treatment while someone is on oral agent? Of course, we said clearly that people on interferon is for 48 weeks. Whether it works or not, you cannot use it beyond that time because you're not going to get any extra benefit. I've heard of some people extending it, but it's actually not a recommendation, okay? Now, for the oral agent, it's usually indefinite, okay? But if someone seroconverts the HBsAg, treatment can be stopped. That is one. It is also said that if someone the viral load has been undetectable for several years, now this is controversial and there's no clear-cut guideline on it. Someone has been viral load negative for very many years, maybe up to 2 or 3 years. You can actually try stopping, okay? But the chances of relapse is very common, especially in our patients that are antibody negative, even after several years. But of course, you can do it carefully in certain settings. Just stop and then see, but not for someone that's been on a few years. The most confident one is if there's HBsAg loss. I mean, they're usually likely to be good with that. And it's important to monitor this. There's a man, when I was working in a teaching hospital, there's a man that has been on treatment for a long time, but just stopped for a while. He came in a passive coma and he passed on. He was a very big man. Okay, so the problem with this oral agent is actually that the aggression within the viral, it's just almost like HIV. The aggression with the viral activity starts when you stop the medication is unbelievable. Okay, the viral load can jump from 0 undetectable to 7 million in maybe 3 or 4 weeks. Okay, ALT, everything just follows. But virological relapse usually occurs before biochemical relapse are happening. So viral load goes up first before ALT goes up, before you can now see, you may not see jaundice, or for some people it can present to like fulminant hepatitis. Okay, so the treatment should not be stopped. And if you are stopping the treatment, that's a physician-led or initiated stoppage of treatment, it should be under careful monitoring. Just look closely and so that we know what we're doing. And in most cases, there'll be a relapse actually. Okay, so we have special circumstances. We're almost ending. Pregnancy, co-infections, and occult hepatitis B infection. So in pregnancy, people who are pregnant should be screened in the first trimester. I think it's supposed to apply everywhere in the world, not just in Nigeria, actually, excuse me. And of course, those who are surface antigen positive should be referred for specialist care. That should not be missed. Interferon gamma is contraindicated in pregnancy. I've mentioned that earlier. Tenofovir has the most extensive safety data in pregnancy. So if we need to treat in pregnancy, tenofovir is the go-to guy. But usually we don't start treatment in pregnancy because hepatitis B is a long-term thing, okay? And the risk and benefits usually is not what we are starting in pregnancy. We should ask ourselves, what are we trying to gain? Okay, but if the viral load is very high, okay, so let me see. Okay, yeah. So there are some criteria that can be met for us to consider treating in pregnancy, which I'll talk about in the next slide. But people that are pregnant that were on tenofovir should continue the drug without stopping. Don't forget, as I mentioned earlier, sudden cessation of the oral agents, the viral load comes with aggression usually. Okay. So, and people that are on other agents that are not tenofovir, don't forget that tenofovir is the safest in pregnancy. People that are on the oral agents should have their medication reviewed such that usually we convert them to tenofovir. That's what that means actually. So to prevent mother-to-child transmission of chronic hepatitis B, that's important. They should get the immunoglobulin vaccine within 12 hours of birth. And the important point for that, which the gynecologist knows very well, is that the medication should be made available. It's not on the day of delivery that they're not looking for it. They now say it's not in pharmacy, it's not in Clara, it's not somewhere. Okay, so it should be available before the date of delivery. It should be available and just waiting for them in the fridge there. And of course, the baby should be vaccinated as standard. And this really reduces the risk of mother-to-child transmission from about 90% without this to just less than 10%. And it is thought that this strategy fails, especially when the mother viral load is very high. Once it's more than 2 × 10⁻⁵, 10⁻⁵, 10⁻⁵, 6, I'm not even sure. So once it's more than 200,000, okay? And this is an indication to start antiviral medications in pregnancy. So we still do the whole panel in pregnancy, even though we think it's unlikely we need to treat them. But don't forget that it's an educated world now. And of course, if someone met criteria to be treated in pregnancy and the person was not treated, maybe the person can be a big man like Dr. Awofisoye when he's going to say, who is that doctor that treated mother in pregnancy? Why am I now treating liver cirrhosis at the age of 40? And you can go and look for a doctor and you can make a case against why proper treatment guidance. So it's important to just look at all these things. And basically, the most important thing again is that screening should be done in the first trimester, and people that test positive should be referred to a specialist or specialist care. And some people can have B and C together. In people that have that, the rate of fibrosis is accelerated, and the cancer risk is also very high. Don't forget, we said earlier, in anybody presenting with hepatitis B or even C, should have at least B, C, and HIV checked. Those three should be documented in their file, okay? And the risk of hepatitis B flare during the direct acting antiviral therapy for hepatitis C is there. So if someone is having hepatitis C and you didn't check for the B and you're treating, B can flare up, can give the person fulminant hepatitis and can cause an issue, okay? In fact, it is said that if you're treating hepatitis B, C, and the person is not responding very well, check for B. Even if the B antigen is, surface antigen is negative, check for the DNA, because it's one of the key reasons why the treatment for C can fail. And so usually, so if there's a rise in the ALT and BDNA that suggests a flare, we should start even while we are giving the finite treatment. That's the 3-month treatment that we give for hepatitis C. We're almost done. I think it's just 3 or 4 more slides. Hepatitis B and HIV co-infection is common. They have common risk factors. And anybody that just tests for this, in fact, you will not wait for a viral load. Once you just do the HCV and HIV and the HIV comes out positive, someone with hepatitis B, just start treatments on that day. You don't need to see the viral load before. I mean, you can ask for it for monitoring purposes, but the person should be on treatment, irrespective of the HIV viral load or the hepatitis B DNA. And we should use ARVs that have viral activity against hepatitis B. Okay, so it's usually a combination of Tenofovir, which is the cornerstone of the hepatitis B oral treatment, with lamivudine or emtricitabine. Okay, if you are treating HIV without addressing the hepatitis B, iris can happen with a liver flare. Okay, so iris can happen with a liver flare. Or if you switch someone from this regimen, maybe because of resistance in the HIV line or something, and you switch a regimen that is not active against hepatitis B, a flare in the liver can also happen. So you should consider all those carrier sets of chronic hepatitis like a TB, like latent TB, can flare up when something else happens. So hepatitis B surface antigen healthcare workers. Healthcare workers should be immunized, including students and housekeepers. Risk for transmission to patients is very low, except in some procedures that are called high exposure procedures, in which you do a lot of do's and a lot of handwork that can make the healthcare workers transmit to the patients. And in many countries, they try to limit what kind of procedures a healthcare worker that is infected with hepatitis B can do. But it is thought that if it's not an exposure-prone procedure, really they can do anything. But for those that do exposure-prone procedures, they should meet certain criteria, including very low viral load and many other things. Okay. Occult hepatitis B infection can happen, and usually when that happens, I think we have a patient or two that has that. When that happens, all you see is that patient has some things that look like chronic hepatitis B. Surface antigen is negative, DNA is detectable, okay, and the core antibody is positive. That's occult hepatitis B. We can also have the pre-mutation, which I mentioned earlier, that is very common in this part of the world, and basically is the one that gives rise to the E antigen negative active chronic hepatitis. Cirrhosis is common. The incidence is about, out of 1,000 patients with chronic hepatitis, about 20 each year will develop cirrhosis. And hepatitis B is the leading cause of cirrhosis in Nigeria, without any doubt. I've mentioned earlier that ultrasound has low sensitivity for fibrosis in the early stages, okay? And in those early stages, those fibrosis assessment tests can give us more guidance. I mentioned that the incidence of the cirrhosis is 20 in 1,000 per year. For carcinoma, is 2 in 1,000 per year. And most of the people that will develop carcinoma will go through cirrhosis, which is good, gives us a window to detect and act first. But sadly, mutation and carcinogenesis can happen independently of cirrhosis, and that's why hepatitis B is a carcinogen. And the risk factors for progression to cancer includes older age, male gender, longer duration of active disease, smoking, alcohol, obesity, NAFLD, and diabetes. So we should survey for hepatocellular carcinoma, and the surveillance we do is to do ultrasound scan, ideally every 6 months in cirrhotic patients. In other high-risk patients, like patients in Nigeria, ideally it should be every 6 months, particularly if the person is older or there's a family history of malignancy. Okay, but in practice, for most people, annually will suffice for convenience and for cost. Of course, ultrasound has more sensitivity. Forgive my typo, please. Ultrasound has more sensitivity compared to alpha-fetoprotein in picking early malignancy. It has to be big to a certain size before it gets AFP levels that would reasonably distinguish between just inflammation, cirrhosis, and malignancy. So there are a lot of extrahepatic manifestations. I'm not going to go through most of them, but the most notable ones is nephrotic syndrome, and hepatitis B is one of the routine things we check in patients presenting with nephrotic syndrome without an obvious cause. They can have vasculitis and PAN. They can also have cryoglobulinemia, but there are maybe up to about 8 other less common extrahepatic manifestations. There are many therapies in development, but I will not go through those. So I'll just go through this algorithm again. I mentioned earlier that most of the patients we see in this environment are e-antigen negative, okay? If you judge based on the viral load and the ALT, the viral load is low. Let's start with low. The viral load is low and the ALT is normal. The person does not require treatment at that point, okay? The viral load is low and the ALT is normal, just needs to be monitored. Every 6 to 12 months, they say, but in practice, 12 months is usually more affordable in this environment, but 6 months is ideal. And if someone that does not mind the stress and will be able to sustain it, then 6 months is fine. If ALT goes up in such someone that you're monitoring, consider treatment or consider liver biopsy. In this person that has a low viral load and the ALT is higher than the upper limit of normal, don't forget that the upper limit of normal in the context of chronic hepatitis B is much lower than what is often quoted in laboratory. So you should always put that in mind. By the time you're seeing 30 something, now it's elevated. Okay? So we should consider liver biopsy and treatment if the ALT is elevated, even despite a low viral load. But those kind of people will probably be monitored for a while first. Now, if the viral load is high, defined by greater than 2,000 units, I hope that we know how to differentiate between units. The result of the viral load comes in units and in copies. So this one, we're talking about units. Okay, if it's greater than 2,000 and the ALT is normal, we should monitor ALT. And if it goes up, and it almost always does, we should consider treatment or liver biopsy. I'm saying treatment before biopsy because biopsy has less of a role these days. I'm not sure when this chart was actually made. And of course, if both DNA is high, ALT is high, the person should be treated. Okay, especially if the ALT, if the viral load is much higher. Don't forget that just slightly over 2,000 is just marginally high. For some people that are reliable, you can actually monitor them and repeat in 3 months, especially if there's not going to be any troubles affording it. Because sometimes you just have this topsy-turvy going up and down on the parameter. But if it's persistent, the person should be treated. So I think that is the end of the presentation. Sorry, I don't have a conclusion slide. Thank you very much.
Thank you very much. Any questions?
Dr. Duba.
My question is this. So let's assume that patients cannot afford a viral load on the panel. Is it okay to make
If you cannot afford viral load,
Yes,
and
or the handle, and we make decisions just based on
let me try to answer. For starters, in workman looking at the tools he has. So the patient cannot afford a test that is critical in management. You must first document that you did not have what you needed to do.
It's the same. It's virtually impossible to make a good clinical on that. Don't forget that hepatitis B, chronic hepatitis B is a chronic condition. It's not acute something like malaria that I need to do now. Someone that cannot afford the viral load now can go and say for the next 6 months if he has to, and do the viral load so that we know what we're doing. Okay? In people that treatment is started based on non-clear-cut things, they are not likely to sustain it. Don't forget that treatment of hepatitis B is long-term and lifelong, usually. Okay? So they're not likely to sustain it. And that's why, I mean, I've laughed many times when I see someone just come and then someone did HUSAD for them and prescribed Tenofovir and said them they should use it for 2 weeks to achieve what? Okay, without any other thing. Not possible. So someone's going to be on a treatment for 20 years. Nah, they have to start well. So there's no hurry. And I usually tell them if it's chronic, there's no hurry. I mean, it's something you should do on time, you should not sit down on it, but it's not like you must do it today or next week or 2 weeks' time. In fact, the positivity has likely been there for the last 10 years, so there's no hurry. And if you are considering interferon gamma therapy, that costs maybe up to 1.5 million naira per course. The person does not have money for viral, so what are we now doing? We better leave the virus. So in real life now, it's not really possible. It's not really possible. It's not possible. And again, it's not an acute thing. So for acute hepatitis B, which is we don't even really need viral load. I mean, we need, but we can do without viral load for acute hepatitis B. So someone comes with jaundice, this looks acute because you need to be able to still differentiate that it's acute and it's not a flare up of a chronic one, which the 5-in-1 panel will tell you. Okay, now we don't need viral load. We don't usually request. I mean, we request sometimes if you think it's just a new acquisition, especially after treating, and then at 6 months just to define that the person has cleared it. But so I think that's how I'll answer that question. Other questions? Dr. Abdul. Okay.
Thank you, sir, for the presentation. The management of chronic hepatitis B, apart from the extrahepatic manifestations, should kidney function therapy part of should consider that the routine investigation of post-viral infections for patients?
Okay, thank you, Dr. Abdul, for the question. The answer is no. It's not a routine investigation for them, even though it can cause extrahepatic, like you mentioned, but not really. If you want to be focused, not really. Okay, but in patients that we are starting on Tenofovir, especially Tenofovir, you have to have a baseline urea and creatinine. I omit it sometimes, which is wrong, but most of the time I try to make sure I do it. And then we should do it 3 monthly. And the most valid, one of the valid reasons for changing someone from Tenofovir to Entecavir is actually if they have renal, if they have increase in creatinine and Tenofovir, you should change. That's the most valid reason. Some people have changed for fancy reasons, but that's the most valid reason. Okay, so I think that's how I'll answer that question. Chief.
Okay, what I was going to say was that on our machines presently, we have elastography. Our elastography is not quantitative. It's just quantitative. It just shows how stiff or unstiff the liver is. So, but you know that for everything we're doing, measurement, we need to have values to know whether the treatment is going fine or the liver is getting worse and all that. So it's difficult for us to predict. We have software or machines that can actually give us the
Values.
values we need for the elastography. So what we do for now, when we do non-abdominal scan, focus on liver, we look for things like surface nodularity and signs of reduction in size of the liver, the architecture and all of that. And of course, end stage is still experimentally assessed and all of that. That will not use to monitor just how we work for that. But later, when we get a quantitative measurement, we can now be doing elastography as part of the workup for management. And hepatitis B is quite common. So I wanted to find out, you mentioned that they should avoid alcohol completely. How many of our guests do we tell to stop alcohol that make us?
Okay, so thank you very much for the contribution, Dr. Kingsley. And I agree that it would be nice to have that fibroscan capacity as part of our arsenal. I know that someone told me that an hospital, maybe the hospital, I'm sure that's someone like told me that they sent him to go and do there and then back. About the alcohol thing, of course, it's compulsory. If you've not told the patient, it's a disservice to the patient, a very serious disservice. And I'll tell you a story that what happened to me recently. So there's a patient I was seeing, Dr. Kingsley knows the patient that was diagnosed with what looks like cirrhosis with ascites recently. And then we found out that the patient tested positive for hepatitis C. The patient has been transfused several in a facility. And I was actually worried that maybe the patient contracted hepatitis C, not just our facility or many facilities, but during one of the transfusions is the most plausible explanation, okay? And she's a female, she's in her 40s, and she's nice. So, and for some reason, maybe because she's female, I don't know, not 40, maybe in the early 50s, more like, I just didn't really talk about alcohol to her, maybe because she's female. But by the way, when the hepatitis C test came out, she tested, the RNA was negative, which indicates that it's a cleared infection. There's no active C infection. And that means the C cannot be the cause of that cirrhosis. Sometimes they can burn out that it's initiated fibrosis, the C burnt out and now absent, but the fibrosis just continues, but it's very uncommon. So I was just counseling about alcohol. That did we talk about alcohol? How much alcohol do you take? The amount of alcohol she told me will stagger all of you. Like, oh really? No, that's the cause of your liver disease. It's not the C. Okay, so alcohol can cause chronic liver disease on its own, one. And then secondly, alcohol cessation at 0 level. They try to negotiate, but hepatitis B is one of the real conditions in which the alcohol has to be 0, like 0. I mean, there are a few other conditions in which it has to be 0, but B is 0 because damage to the liver is cumulative. And I mean, you can see the things I showed about the outcomes. Progression to cirrhosis, progression to hepatocellular carcinoma is higher in people that consume alcohol, no matter the level. So it has to be 0 for people that have chronic hepatitis. So thank you for that contribution, Dr. Kingsley. Chief, sir.
Thank you for the presentation. One comment on the question. The comment is, thank you for the presentation and we work hard. So that we will know the expectation, what we tell patients, especially, I don't know if viral load and everything can be done from central area, because most of the time, by the time the patient comes, you look at their viral load, you look at we'll just follow you up, there's nothing. Most of them are disappointed because they are coming with the expectation that once they come, a drug will be given, and that's okay, you are positive, but with the stage you don't need treatment. Most of them, it usually comes like a shock or disaster, so that we'll be able to give them better education before we send, if we have to send.
I think, Chief, that a lot of the education, usually people want education from authoritative sources, that is from people they know that this is like really hits. But I agree with you that many people, it's not just whether the person was referred or the person was found there. I use the example of like it gives them psychological sleep and they want you to be doing something about it. Okay, but usually by the time I counsel them and tell them that the treatment is usually lifelong, once started, usually they cool down a bit actually. That's okay. If you tell me that I'm going to be doing this, so I'm going to take this for the rest of my life, and someone's telling me that okay, we can delay starting by 2 years. I mean, you'll be happy. You'll be happy. So when I do that and I put a good amount of education with it, that's counseling them on on all those parts, it helps a bit. It helps a bit. And people want to hear from authoritative sources, that's the truth. In fact, they just want to hear from authoritative sources. And by the time you tell them authoritative, they know that, okay, they don't have to go to the next chemist to ask them that, okay, I have hepatitis B. Some of them will go and test again. They will do something in their office. They'll go and test again, okay? And in view of that, I need to just mention something because many of our doctors don't know that if someone is treated successfully for chronic hepatitis C, I'm talking C now, the person remains seropositive lifelong still. So the what do you call it now? HCV antibody will remain positive. It's the RNA that will disappear and should disappear. So if someone said I completed my 3 months treatment, you just need to ask them the treatment they had. If the treatment they had is a modern 3 months direct antiviral treatment that's fairly expensive, costs maybe more than 500K. Once you just know that the treatment is in the last maybe 3 or 4 years and it was in a specialist setting and it's for 12 weeks, that's 3 months. Usually that's the current treatment, okay? The antibody will be there. If you want to find out whether the thing has totally gone and it didn't come back, it's the RNA you do. So it's not, because I've seen a few patients that someone just saw their result that, that means the treatment I did in National Hospital last year did not work. Okay, it's the cRNA that will tell you whether there is. So the cRNA should be flat in a successful treatment, but the antibody will be long-term positive.
Okay, so the question.
Yes, sir.
Is there a place for intermittent interruption of Tenofovir in patients that's viral load has gone as a non-recordable? Then number 2, what is the role of Nicolene essential forms?
Okay, thank you for the question. That's a very good question. For me, and for guidelines, there's no role for intermittent interruption. The truth is that chance of resistance is there, and we don't want it. Now, yes, tenofovir has a very high ceiling of resistance, and resistance rate is not common, but if it's abused, after a while, it will just be like lamivudine in that patient, and if someone is resistant to the drug, there's really no hope. There's no hope, that's the truth. There's really no hope. I mean, if you are resistant to tenofovir, you are likely going to be. So we don't want to encourage it at all. Now, there's still a role for that one that we talked about earlier. That is someone has been, Viread has been undetectable for years, maybe 2 or 3 years. We can agree to stop it and see what happens and monitor closely, of course, at very serious specialist supervision. And then if it goes back up, we just know that, just release the patient. And I told you, and then you go back to it. And it's not likely, it's not even an approach of someone that's likely to disappear. But Nigeria bastardizes all sorts of things. The way we bastardize metronidazole. I'm sure if people in the Western world heard the way they use metronidazole in this country, they were like, really? You just having rumbling in your tummy and you just okay. So if they do tenofovir like that, it's a matter of time they'll be resistant to it and it won't be really good. For the second question, essential phospholipids.
There's no rule.
Chief, wait, let me answer to you. So there is technically no rule, okay? But when there is a lot of liver inflammation, it is often given to, if there's ALT, if ALT is really elevated, we think it can help, okay? But in terms of it's not evidence-based, so there's no rule in that time. But now for the long-term chronic hepatitis, there's no point, I don't give them, okay? But number one, if someone is on interferon, which has immunomodulatory activity, usually for that 48 weeks, just maybe slightly increase the chance of seroconversion, can do that. If someone has a flare and the ALT is elevated, but in the presence of normal ALT and the person is not on any antiviral treatment, it's a waste of time.
So, it doesn't really affect seroconversion.
I don't think so too.
The role is mainly in acute hepatitis settings. And practice-wise, I would say that Silverine is a better option. Perhaps a better option than the Nicolene. But the Nicolene has a very good role in BP. Let me say it that way. BP. Private practice. Somebody comes down, hepatitis B, saying they don't want to treatment, they have come all the way, they say they said all they will see, they pay the travel. So some people they now come and meet me and I'll tell them not to, I will give it to me.
But usually when we do that, we should tell them that it's just a liver supplement, just helps. Okay. Because I've seen some people that will tell me that, but they've given them treatment for the hepatitis B before. I say, really? And they said, what? Now they gave them something for 2 weeks. I said, yeah, really? That was a miracle drug. Okay, so thank you for that comment and addition, Chief. There's any other questions there? Frankly, yes.
Before now, we used to hear about hepatitis B and like D co-infection. So I don't know if it's still, I want to know if there is any prognostic indication when you have a co-infection of hepatitis B and D. And then how do you actually test for hepatitis D?
Okay, thank you very much. D, yeah, D. Thank you very much.
I still have one question.
Oh, yeah.
And then another, if Azar asked one of my questions, the role of Ebola, I've seen a patient that was referred from, that came from another hospital. He said the doctor, he was tested positive for hepatitis B surveillance D. And then the doctor placed him on Ebola and told him that all is well, that he can go home and relax. And eventually, we did viral load and it was very elevated and started treatment. And then another question I have is when you have a co-infection of hepatitis B and C, how do you go about the treatment? Considering I think they use different drugs for treatment of both. So how do you go about which one do you treat first, or do you treat both of them? That's if the patient needs treatment. And then for pregnant women who test positive for hepatitis B, we should also remember to counsel them to make arrangement for immunoglobulin. That's when they give birth. The child is supposed to get immunoglobulin. And then also the child will be vaccinated for hepatitis B. Then my final question is, if a patient tests positive to hepatitis B surveillance, would it be a reason to screen for other sexually transmitted diseases? In as much as we are thinking that most of the infections are through particle transmission, should we still go ahead and screen for other STIs? Thank you.
Thank you very much for your question and your contribution, Dr. Frank. So for the hepatitis B and hepatitis D infection, yes, it's important to recognize and it's important to treat. Okay, but the key thing I'll mention there is that, of course, I believe that we all know that there is no specific treatment for D. You don't need to treat D. It's only B that enables D. But what is said is that oftentimes, if you're monitoring someone long term for B and you notice a flare, one, or you're treating and the treatment is apparent to be going smoothly, and you notice a decompensation, you should suspect a D superinfection on the B, okay? But it doesn't really change the treatment because we know that if we treat the B well and aggressively, the activity of the D will be very minimal, okay? So usually it's suspected in someone either with a chronic carrier state, everything has been well, and there appears to be a flare, one, or someone that is on treatment, and then there's a decompensation somewhere along the line the treatment. Unfortunately for D, it's not routinely tested. I'm not even sure there's anywhere they do the test in Nigeria, so I've not seen anybody that was tested for D before. It's just a fancy thing, okay? But it happens, and it can make the treatment, cause a bump in the treatment. But the treatment, again, is to be more aggressive about your B treatment than making sure the person is using the medication that is to be used. Now, talking about I agree with you on the interferon, on the Livolin, and the fact that many doctors or many places, the patient is miseducated. Is miseducated about the hepatitis B and the treatment they're giving them. I've seen someone that told me that they had just one injection for 2 weeks. I'm like, what are you talking about? There's nothing like that, okay? So anytime someone says that they have received treatment for their hepatitis B, please ask them what treatment they received and ask them to describe it. Most of the time, they just realize that it's nothing, okay? Now, talking about the hepatitis C and B co-infection, usually the treatment should be started at the same time for both of them. Of course, the duration of, don't forget that the oral, now we're talking oral, it's going to be oral, okay? The oral hepatitis B drug, particularly Tenofovir, is extremely well tolerated, extremely. Most people just feel as though they use paracetamol or they don't feel anything. So it's very well tolerated. And interactions is not so much of an issue, okay? And we know that if you treat the C first, it is known that the B will surge up. It causes a flare of the, so you should never treat the C first, okay? Some people have said that you can start treating the B first, before you start treating the C, but Usually, you just start both of them together for most of the recommendations. And then, of course, the treatment for the C is just for 12 weeks. After 12 weeks, you stop the C, and the person continues with the treatment of the B. In those days in which C used to be treated with ribavirin and interferon injection. So they give interferon for, I think, a year or two for ribavirin. In those days, by treating the C, they are offering interferon gamma therapy for the B as well. But as I said, in most cases, the interferon therapy is probably not going to work. So I think I've answered the two questions you have asked. Which one?
STIs.
Oh yeah, about the STI, I would say no. I would say no. Except HIV. So HIV, HCV should be done. HIV, HCV, HBsAg, the two of them, anyone that has any one of them should have the rest. Okay? But for the STIs, again, because hepatitis B is not so much of an STI, it can be sexually transmitted, but it's primarily blood transmitted. Again, as we said, the vast majority of infection in our environment are perinatal. And if you're screening most people for, if you want to check them for gonorrhea, they won't come to your clinic again at all. But nowhere is not recommended anyway. So most transmissions are not sexual. Thank you, Dr. Franklin, for the questions. Chief, sir.
Of course, we know that for a hepatitis B negative, positive mother who is going to have a baby, is supposed to have the antibody ready for the baby that is coming. But is there no interaction between, because we're advising that both the antibody and the vaccination should be done at the same time. Will the antibody not destroy the antigen that is being used to stimulate antibody production for the baby?
Very good question, very good thoughts, Chief. But for some reason, the answer is no, it doesn't. I'm not sure why. But for some reason, I think it's because of the nature of the antigen, of the vaccine. It's likely because it's not a live vaccine, it's a recombinant vaccine. So it doesn't check. It's advised that both of them is given within the first 12 hours of birth, both of them. And but it's a very sound question. I mean, we know that many antibodies can clash and can have immune complex stuff. So thank you for that question. Something I would like to read a bit more about actually. So I'll answer Dr. Vivian's question, and I'll encourage other listeners to ask their question on the screen, either in the Q&A aspect or in the chat box. So it is believed that people with chronic hepatitis B should cut down on protein diet. How true is this? I don't know. I hope nobody says this in the hospital because I've fought aggressively on it before. There's nothing like that. There's no dietary changes for chronic hepatitis B. The only is alcohol, and it should be abstinence. Abstinence from alcohol. There's no dietary changes at all. Oh yeah, no, it's not dietary. It's not dietary. So thank you, because I didn't include that, and it's part of what I should have been increased. So alcohol, other medications, even indiscriminate medication usage, okay? Even medication that has normal liver side effects, you just think twice in someone that has chronic hepatitis B. There are many medication stuff, okay? Things like immunosuppressants, chemotherapy, all of them, you have to think twice in someone that has chronic hepatitis B and consider, for people starting chemotherapy, for example, or serious immunosuppression that have chronic hepatitis B, it's recommended that you just start them on treatment just to cover before you do whatever immunosuppressive thing you want to do, okay? But in terms of diet, no dietary restrictions. They can eat anything they want to eat. That is LD, but they should abstain from alcohol. You want to say something, Dr. Sandra?
Yeah, I think I read something about chronic liver disease when there's hepatic encephalopathy. That's when the protein restriction.
Don't forget that chronic hepatitis B is different from chronic liver disease. Yeah, so if you have got to the point where you have chronic liver disease
with hepatic encephalopathy, that's a different situation.
Have chronic liver disease and do not have hepatic encephalopathy.
It should be on a normal protein.
But what happens in those patients is that they have a worse prognosis. They become truly protein deprived. Their albumin, their liver is not producing enough protein. They are not taking enough orally, so their albumin drops drastically. They have a higher mortality rate. So except they have gotten to the point of hepatic encephalopathy, you still, at best, you just people marginally, but most times, no protein restriction is no longer recommended.
Thank you very much, Chief. And I will add that the main dietary stuff, this is not chronic hepatitis B now, is non-alcoholic fatty liver disease. There can be dietary stuff. Abi? So you may put the person on a healthy diet, lesser carbohydrates because you're treating non-alcoholic. But for chronic hepatitis B, it's just alcohol. And I've seen many patients that have been on even no protein for years. And carrier stage, I mean, that means for 40% of Nigerians should be on no protein or very low protein diet. There's nothing like that. But it's alcohol. And alcohol is the one that many guys, particularly males with chronic hepatitis B, struggle with. They're just like, at all. And many of them still, and you need to ask them at every consultation because it increases their chances of progression to both cirrhosis and HCC. So, someone says for patients that cannot afford the 5-in-1 panel but have markedly elevated ALP levels and AST levels, you corrected it, and surface antigen positive, please maybe comment. First of all, I don't know, is the 5-in-1 panel expensive? Because I've heard it, I trusted it.
And how do you analyze the SAG positive?
It's SAG. There's patients that have chronic hepatitis B, basically. High ALT, but cannot afford the 5-in-1.
For that, as you must have done DNA. You need to do DNA, and DNA is much more expensive
than the 5-in-1. And if we go back to, let me show this slide. If you go back to my immune reactive phase, look at that, ideally, go back to the immune reactive phase. It's actually the serology, the surface antibody that will help you distinguish between this phase. So you need the 5-in-1 panel to distinguish people that are here, where's my mouse, that are here, and those that are here. So the truth is that chronic hepatitis B is a long-term disease, and people should be patient enough. People that have financial issues should be patient enough to build up funds to. If you can't do 5 months, there's no way you can sustain Tenofovir for even 1 year. Not about 5 years, 10 years, 20 years, 30 years, I don't know. So it's better to have things clear cut so that you can tell them in strong terms. It's people that did this incomplete test that someone now give them drugs for 2 weeks and tell them that is all, I'm doing treatment. I don't know. Okay, so I think, okay, any other questions or comments?
Let me just, while you were presenting, I made some notes.
Yes, sir.
I hope I have to be server now.
Just a moment.
We've tried to summarize. I hope we can get the summary. Because at the end of this all now, like somebody will say, last. So what do we do when we go after all this stuff? Let me see. Okay, there's one here. Good. Where is it? So based on what he presented is what I'm sharing. I don't know whether this is the one that he's sharing now. So okay. Yeah, so based on what you presented, this is what I think. Investigation, standard investigation, hepatitis B surface antigen positive, Abi. What we do is ultrasound. We wanted to buy Fibroscan at one time. The money was so much, I knew nobody was going to pay for it. The machine was maybe 80 million or something like that, or 60 million or something crazy like that. So it means that the unit price will be high. So that's medical economics. So ultrasound, LFT, full blood count. You use the LFT and the full blood counts to do your accurate score. Just go online. First, I've told all of you now, if you have WhatsApp on your phone and you don't have a medical calculator, you are not a serious person. So let's get MedCalc, I think, MDCalc, which was you just have it on your phone. It's QS Calc, and they have multiple things. You can make your write-up look like a very, once you add score and all of that, even if you are referring. So with these two, you can easily calculate your accurate score. Then HBV DNA, HBV 5-in-1, anti-HCV, anti-HIV. Now, don't disregard the upper limit of normal on the ALT. If it's greater than 19 in female, it's high. If it's greater than 30 in male, is high. So all those ones were saying high ALT, high ALT. We're talking of 90. So if it is 20 in a woman, it is high. Okay? So this is what we do for investigation. Maybe we can even create a, like we have for CV risk screening. Maybe we can create one pack like that. I just push all of them. So hepatitis, newly diagnosed hepatitis, just pick it. And then don't forget to add the ultrasound. Then liver biopsy, I didn't get the third one. For HB negative people with normal ALT and HB greater than 2000, consider for liver biopsy. If their ALT is high and their hepatitis B is relatively normal, consider for liver biopsy. The third one I can't remember.
The third one is in the HBV. The viral load is low, ALT is normal, but there are things that suggest liver activity, most likely ultrasound.
Yeah, exactly. So you have other markers of chronic active hepatitis. Sorry, they've changed the name. It's no longer chronic active. Other markers of inflammation in the liver with normal ALT and low HBV. Then treatment, initiate and monitor in specialist setting, but they may follow up in your setting. So every time educate, cease alcohol, lifelong monitoring, remind them, and then risk reduction. Those to be treated. So who will you treat? High viral load greater than 2000, except those that have extremely high. So some people have 20 million. HBV DNA comes at 20 million with positive HBe antigen. Those ones we typically don't treat. You monitor. Okay, so what will happen typically? They are likely having an acute phase. That's the time you can give Silimarin, Livolin, bed rest, check for jaundice, whatever, and then repeat again in 3 months or 6 months. Those who treated are those with elevated ALT, using those cutoffs we talked about, or features of cirrhosis or the complications. So cirrhosis on ultrasound, APRI score, okay? And then if the patient has HCV or HIV, try and use hepatitis B active medication. These are the people to be treated, summarily. Okay? Now, interferon gamma, pegylated interferon. It's about, it used to be, many years, it used to be 30-something naira per week. So it's about 1.8 million for a year's dose. The patient must have the money together at the beginning so that they don't start and stop. So they must have the money. Typically, they pay in the front desk, or if it's HMO, we get approval up front for all, including hepatitis C. So don't let them be paying, okay, when they get money, they will come. So, so people that are young, less than 40, high ALT with low viral load. When I mean low viral load, that means the viral load is not in the millions, okay? But it's greater than 2,000. If it's less than 2,000, so greater than 2,000. Genotype A or B, we don't routinely do it. So if somebody fulfills these other criteria and you want to decide to start, you may decide to ask for hepatitis B virus genotype. Okay, so then female sex, consider it more, and then there must be no evidence of cirrhosis, either APRI score or ultrasound. Stop treatment interferon gamma if hepatitis B surface antigen quantification is greater than 24,000 on the 24th week. That is that's about 6 months. Then, in fact, sometimes some people start by 12 weeks. After 3 months, they test. Or if there is no significant reduction in hepatitis B, HBV DNA, or if there is severe derangement in full blood count, they could have a very bad neutropenia or very, very bad, and you may have to stop. So don't forget full blood count before. And at 12 weeks, repeat full blood count. At 24 weeks, repeat full blood count, and then TFT. Treatment, first line is Tenofovir or Entecavir. Okay, it's first line, lifelong dose, once daily. So people might be coming for refill with you. When they come, check that they have done the surveillance in the last 3 to 6 months. Consider stopping under a specialist guidance only if greater than 2 years of undetected HBV, undetected HBV DNA. And then you must continue monitoring. Typically, it's every 3 months. So if you stop, every 3 months you must do HBV DNA. So if you are thinking of stopping and the person cannot do HBV DNA every 3 months, or just continue the drug. Okay? And then in pregnancy, you continue it, but you will not start in pregnancy except special conditions. Every 6 months, while on drugs, do viral load, LFT, tumor markers, and ultrasound every 6 months. Abi? Yeah, that's a simple summary, right? Yeah, so we can take this one, maybe we can put it somewhere. We can just have this one on your laptop and you can easily do this one. After all is said and done, if you follow this one, you're likely to be right. Anything that cannot fit into any of this one, you're not sure, ask for help. Okay, great. Please, those people that say they've treated hepatitis B successfully and all that, please don't join them. Okay, I've seen it so many times. There's one young guy I saw, I can't forget that guy. He was 30-something. Okay, Nigerian breeze or so. The guy came and I just touched his stomach, I just did like this. Hey! And the guy said, I saw the doctor 2 years ago. And the doctor said, no problem, I should just, don't worry, everything will go, that's how it is or something. So as I was talking to him, counseling him, every so often the guy would say, but I saw the doctor. Every so often he said, but I saw, as in, I went to the hospital. Doctor said I should not worry. He kept on saying it. He died within 3 weeks of making that diagnosis. A young guy. I cannot remember, I cannot forget how the guy kept on shaking his head, but I saw the doctor. But I saw the doctor. I can't forget with his young wife. I can never forget. So I don't know which doctor that is. I can't ask his daughter, you know. I don't know which doctor. He said doctors in Abuja. But you don't want to be that doctor that says, guy, don't worry, just don't take protein and then take Evolin and come back later. But that's lazy doctoring. Okay, great. I think this is a good thing for us to have to go. Okay, any questions? Any questions? Any queries? Any issues? Great. So, oh, okay. Thank you. So we're going to play a video. I'm going to play a video. I hope it comes out there. Stop here. Share computer sound.
By the end of this session, you should be able to explain what.
Is there any volume setting here?
No, it is. I know that. I know.
Okay, so we're going to listen to a video and then we're going to just talk about it briefly, okay? I will likely do a small test on it. So I want you to pay close attention. It's just 9 minutes.
Session 4, Effective Communication. By the end of this session, you should be able to explain what communication is, understand the 4 communication styles and behavior, develop effective listening skills, and understand how to use various communication channels. How do you become a better communicator? To become a better